Okay, thank you for joining our working group today. We do have a fairly quick agenda. I know the timeline looks longer than what it will probably take, but we do thank you for joining and participating in this effort. I'd like to kick off the meeting first by starting with the minutes and the approval of the June 24th minutes. If you've had a chance to review the minutes and if there are any corrections or changes that you'd like to offer at this time, we'll certainly take those. If not, I'll take a motion for approval of the minutes.
So moved. This is Jed Burton.
Thank you, Jed.
Yep,
Do we have a second?
Second, Adam.
Thanks, Adam. Okay, all in favor? Any opposed? I guess we'll say any opposed. Raise your hand or speak up. Okay, thank you. So the minutes, motion has passed to approve the minutes, and those will be posted to our working group website, as well as you'll find the recorded session there as well. So thank you for passing those. So I'm going to switch over to a slide deck that we're going to use for a moment and go through a presentation just to guide our discussion today, as I have used in prior weeks. So first item, we said we would bring our operational issues to this group for discussion and some visibility in anything that was brought to our attention. Wanted to just update you first that there have been no new issues identified in the last 2 weeks since we last met. And there are 2 remaining issues that are ongoing or that have not been resolved or identified here on the tracker. So I did remove the 2 that were identified last meeting because they have been addressed and resolved, and we've left the open issues here. So are there any questions about these items? Okay. Nina?
Let's see if my microphone works this week.
It's working.
Yay, finally. Regarding the number 1, the IOP bundle issue, it just says the resolution date is ongoing. Is there anything that I can do to be of help with that? I know I was the one I think that was started kind of spearheading that. Should I just call you and maybe set up a separate meeting to talk about that?
Yeah, Dave, would you like to comment on that?
Sure. The biggest obstacle to that right now is the PRISM system coming online. And so any changes would delay that, which is not going to be delayed, we've been told. So that's the biggest hurdle right now.
So Nina, we have a new information system that's being implemented on January 1st. And our coding and our work that has been designed for that system is in place. We are still doing some work, but some of these changes would have to be implemented after January 1st. And so that is a bit of the time frame that we're looking at for this. There is policy work that can be done to work on this issue in the meantime, but the programming and implementation would be after the January 1st timeframe, is what I believe Dave was mentioning.
So is it correct to assume that this is going to happen? It's just a matter of time and the new system, and we'll just keep looking at it in January when you have one hurdle finished. A big hurdle. Okay, thank you so much. I appreciate the update.
Yeah, and then with that, of course, I mean, that could take some time. It's the programming as well as, designing the rates and the payments and all that. So it's kind of the policy work that goes with that. But we are committed to working on that.
Great. If there's anything I can do to be of help, just let me know, please.
Thank you, Nina. Yeah, appreciate that. Okay. If there are outstanding issues that you have identified as a provider, as just part of this working group, again, we invite you to work directly with David Wild, who can help look at claims, look at any billing issues, and if there are more on the ground issues that you're experiencing, we certainly want to facilitate that work. And so Dave's information, if you don't have it, is at the end of this slide deck, but almost all of you know Dave. So, okay, we're going to move to the next agenda item here. Thank you, Dave, for sharing your contact information. Okay, we went through this last week as a discussion summary list. And we've taken our time to walk through these various elements of, with an ultimate goal of achieving a patient-centered, person-centered approach in the work that we are undertaking and looking at an integrated delivery model for the TAM population. The three different areas that we've spent time evaluating have been utilization data that has come through our Medicaid claim system. We've also spent time asking you as providers in the field what coordination strategies have been successful in working with this population, and what are the essential pieces that we will need in designing a benefit to help achieve our goals of success and our outcomes with this group. And these are also listed here. Last week, we spent time talking about outcomes, quality measures, some of the elements that we would use to define success that could be used as some of our metrics as we develop models or design models of care that could be integrated in their approach. What are some pieces that we would want to look at with regard to outcomes in defining success? I did go through, as you look, this column last week was actually blank. We had our discussion. I went through our minutes and I did pull some of the pieces that were discussed. These were mentioned were some of our standard HEDIS measures and HEDIS measures or other standard outcome measures. One specific item that was brought up was follow-up after hospitalization. The Medicaid core set has many measures that specifically address the care of this population and some of the outcomes of interest. And so we could use that or elements of that as a guidepost or one of our outcome measures. Generally, there are physical health outcomes and behavioral health outcomes that we could identify and look at. Adam and others looked very specifically at the patient and how they're responding to treatment. Are they engaging in treatment? Do they have a reduction in symptoms? Are they have reduced use of drugs and alcohol and other important factors of rates of incarceration or reincarceration, employment, housing, healthcare engagement? Brent had mentioned a scorecard that had been used before. These items that are listed on the defining success side are certainly not complete. These were the items that have been brought up. I'd like to add to this as we go through our working group discussions and make sure that we identify those elements that are important to us. But before we move forward, I wanted to actually step back to our first column because Brian on our Medicaid team in the director's office has pulled utilization data that we have represented to you earlier and shared with you the longer document around utilization data that looked at this population as a whole. We said we would bring you more data as requested or as the time allowed. And one of the things we wanted to do today before we move into really the working effort of our meeting in the next steps was to actually look at an important piece of this population, which many of us in different settings that we may work in have focused on. And these are our high utilizer group. So of our TAM population, these are of course our utilization data from claims. It gives us some information, but it also left us wondering, like, what are we missing? What are some gaps? And what data do we not have that we might expect to have? Okay, so I first want to recognize that while we do have utilization data that's described here in these bullets, there may be gaps as well around what maybe we don't see. A piece that we wanted to take some time to walk through with you today was our high utilizer group. And we focused on the top 10% of the utilization and wanted to actually compare and contrast that with you compared to sort of what we see of the overall population. And so I'm going to transition over to Brian to just have a few moments to share that data with you. And we're going to reflect it against some of our total population use. And then we'll also share this data form with you as well, so that as you move into our subgroups, we're going to break down into subgroups after in the next phase of our meeting. And I think to use both may be helpful for you. So Brian, if you would like to go ahead and take over presenting. Thank you.
Yeah, absolutely. Actually, sorry, I have two documents that look very similar, and I chose the wrong one to present. Let me change that real quick, and I will be back on track. Okay, thank you, Jen. So yeah, this, as Jen was mentioning, this is designed to be pretty similar to the document that you have already seen in our first working group meeting that was on May 25th. So if some of these graphs and layout look familiar, that's by design. This is intended to allow you to compare to the broader TAM population and see how the 10%, top 10% utilizers differ, and in some cases are similar. So I will probably go through this quickly and allow questions. This will be distributed to you after the fact. So we can certainly follow up on any specific questions you have. So this is focused on that top decile. As previously mentioned, they account for about 53% of total TAM expenditures. And you can see that in this graph, 61.4 million is the dollar amount that they account for, and the rest of the dollar amount figures are shown below. So similar breakdown, justice involved is still the majority of this top decile. However, those experiencing chronic homelessness did increase, so that slice of the pie increased when you focus on the top decile, meaning there's a disproportionate portion of them. One thing I wasn't expecting and is kind of notable is that the proportion of females increased when you look at the top decile. So the broader population is 79% male, but within the top decile, it's only 70% male. So yeah, that's an interesting observation. The language is almost exclusively English speaking and predominantly white, non-Hispanic. Again, a big piece of individuals choose not to disclose their race, which is their right. Population is even more densely concentrated in urban areas, and 2/3 of the individuals are residing in Salt Lake County alone. And then 10% in Utah County. Everything else is single-digit percentages. As far as service delivery, by definition, these are high utilizer clients. So the fact that we're seeing high percentage of utilization is by design. But what we do see is nearly all have had a medication dispense. So they had a contact point with the pharmacy. Nearly all also had some contact with a primary care physician. Only a very small amount, like 8%, had a single primary care visit. So that in most cases, they are like frequently visiting a primary care physician. Again, there's some limitations on what conclusions we can make from that claims data, but just wanted to point that out. 83% laboratory and diagnostic service. For the most part, this is urine drug testing, which goes along with the high use of, or the high diagnoses of substance use disorder and high substance use treatment rates. When it comes to medications, 2/3 have received antidepressant medication. More than half have received anticonvulsants and analgesics. And then nearly half have received antipsychotics. And then when it comes to chronic conditions, so this decile contains 1,028 members, and 976 of them, so that's like 95% of them had a substance use disorder. Perhaps not surprising, but it is notable that 95% of this decile has a substance use disorder. Then you can see the following: depression, bipolar or other depressive mood disorders, and other chronic conditions listed. This is not the full set. This is just a subset of chronic conditions.
Brian, I'm sorry. Can you go to the previous slide real quick, the medication?
Yeah, Dr. Carlson, yeah. Any specific question here, or just did you want to look at this a little bit longer? Oh, sorry, you're muted.
No, thank you. That's good. I got what I wanted.
Gotcha. Okay. Yeah, apologies. I'm trying to keep it a little bit brief, but like I said, we're happy to take questions that we can respond to in time. As far as the number of concurrent chronic conditions, 200, so this is roughly a quarter, have just a single chronic condition, and then more than half, closer to roughly 70%, have multiple chronic conditions. And then just one other note that when it comes to co-occurring behavioral and physical health conditions, 743, roughly 3 in 4, have a combination of a behavioral and a physical health chronic condition. And then when it comes to cost, last slide here, whereas the broader TAM population costs roughly $1,200 per member per month, these individuals in the top decile cost about $5,000 per member per month, with the breakout of their physical, behavioral, and dental components there. So, like I said, I'm happy to take any questions.
Hey, Brian, Pat Fleming, just on the distribution of the top decile across the state, being concentrated in the urban area and especially in Salt Lake County. One of the things, I mean, we all know this population up until we got TAM really has not had access to really good care, right? So they've been going a long time without being able to really get good care. And with the advent of TAM now, we finally have an opportunity to get in there and see if we can get these folks back on their feet and get their health in better shape. But one thing I think that I would really like to know, and I don't know if we have any information or how we could get this, or maybe it's something we need to be thinking about in the future, is that what is the county of origin? Because we know that they're going to come to the urban areas, especially Salt Lake County, because that's where a lot of the services are. But now that we have a health benefit for these individuals, having them get access to care earlier in their diseases is really going to be the key. They can stay in their local communities. So that's something I'd like to throw out for the committee, just to think about a little bit. Mm-hmm. I spoke with Wayne Niederhauser about this, and we had and Tom Ross from CCJJ, and we had a pretty good discussion about it. But it would really be nice to know that, so that we can make sure people are getting enrolled in TAM in their communities. That's the key thing. And secondly, that they're getting early access to care because they have a health insurance benefit now. So that's something I just like to throw out to the committee. We don't want them to be concentrated in these urban areas because they wind up being on the street and everything just gets worse, as we all know. So that's just a comment I wanted to make.
Thank you. Good point. Emma.
Yeah, Brian, I'm kind of putting you on the spot here, but I'm just curious, the high utilization of inpatient hospital and the ER, you probably don't have this yet, but I'm just wondering, do you have a sense of whether or not it's their physical or their behavioral health issue that's getting them into the ER? And just something maybe for future discussion.
Yeah, it is a good question. I did look at the most common diagnosis for ED. It was, well, actually, I'm not remembering. I did see suicidal ideation as the most common diagnosis for one of them. And I can, it's 30 more seconds, I can pull that up.
You can bring it back, Brian, too, as we just kind of take another look at the data.
Yeah, I think that would be helpful maybe for a future meeting.
Good question. Any other questions on this? Again, this is information for you to not, I know you can respond to it now, but we want to share this with you and have shared some of this with you already so that it's useful for you as you're evaluating and doing your work on the next steps. So, and certainly we're happy to evaluate things differently too. I mean, one of the questions I've also had is frequency of use, frequency of visiting the PCP. So Brian mentioned that around, this particular group has more of their care coming from the PCP and not as much, substance use treatment. Certainly we're seeing 81% receiving care through substance use treatment, but not as much through mental health treatment providers, billable providers in this. So if there are other questions that you have, we're certainly happy to drill a little bit deeper or just approach it differently. So thanks, Brian. Do you want to comment on this on your note?
Yeah, just to read the note, because we do have some people on the phone, but the most common diagnosis for emergency department was suicidal ideations, and for inpatient, it was alcohol dependence with withdrawal.
That's great. Thanks, Brian.
Mm-hmm.
I think, Joel, you may have been first. The question.
There's kind of a national movement to get the HBAI services covered, which is kind of like the front end intervention type services. So in a lot of cases, that may be relevant to trying to avoid some of these higher cost care, and especially as we implement receiving centers and MCOT and ACOT teams. There is a national push, a pretty heavy push, and so it may be worth considering that as a state too, especially if we can get cost savings data.
Yeah, Joel, I'm sorry. I don't know if others caught like the first part of your statement of what's being implemented. It just kind of faded a little bit.
Oh man, I even put on nice headphones for this reason.
Sorry.
That's all right. So I was saying HBAI coverage.
Oh, HBAI coverage. Sure. Thank you. Yep. And we're following up on that question, Joel. So,
okay, great.
Okay. Thank you. Thanks for the comment on that. And Nina.
I was wondering about the role of housing in terms of being considered as a service delivery. I recently toured First Step House and was very impressed with Sean McMillan and their program there and how they're targeting some of the very same issues and populations we are, and they're doing it in lots of different modalities, but often it's the wraparound services and housing. And I'm wondering how we might be able to bring them into this picture, because it sounds like they're doing research and almost identical concerns. They have a high group of carcinogenic individuals. They have the rehab. They're also doing research and studying the effects of long-term housing, and have saved, from my understanding, and with other models around the country, just tens of thousands of dollars in this high utilization population. And I'm wondering if we can bring housing and housing models into our discussions of service delivery.
Yeah, Nina, thanks for the recommendation on that. I think you're right. There are other states that are using housing models in their management of this type of population. And I think that's something you could take back through the work groups that you have as we evaluate what are the essential services that this group may need and benefit from in order to achieve success. And then we can evaluate all of those things against CMS requirements and the steps we would have to go through as a Medicaid agency to get those types of things covered. But I know that there are some states that have looked at transitional housing solutions for individuals coming out of facilities, for example, as a way to achieve better success. So I think this is great. And if the subgroups that we're going to break up into can actually evaluate and look at what's been successful in other areas, we'd love to talk about that. It's great. Any other questions, Joel? Do you still have your hand up, or? Okay. Okay. Thank you, Brian. Okay, we're going to just pivot back where I was here. And I don't want to jump through this too quickly, because I know last week I kind of presented and moved on. Are there any comments on this slide before we move on to our next steps? Are there items that you feel are essential to add today, or we know we can actually add them through our breakout work groups we're going to be doing, and certainly we can make these lists more comprehensive?
This is Johnny Da from 4th Street. I think it's kind of in there under your coordination strategies. You have some stuff about hotel stays and supportive housing, but I think recuperative care or respite care services, which I know the state is already kind of working on, but it is, it's really critical, particularly for the unhoused population.
Thank you.
And it ties into, I think, hospitalization and ED utilization.
Okay. Thank you for that comment. And just to respond to the work that the state is doing on respite care, we actually did meet with CMS today, and that is the piece of our waiver that we are working on is the respite care piece. So we are actively dialoguing and working with them on their questions. And as they have more research questions for us, we will take those back and respond to them. But we are working on that piece right now. So thank you for mentioning that. Pat?
Yeah, Jen, I was going to mention, I haven't seen it on here specifically, but just the opportunity to get people enrolled. It can be a little bit difficult if they go through traditional systems. And I know a lot of the agencies that are on right now, 4th Street, First, Step House, Odyssey House, I know they do a lot of enrollment themselves in Medicaid, but making sure that we have a broad, robust enrollment system that is not a barrier itself to getting people signed up is really key. And I think especially in rural parts of the state, very important. I mean, just thinking that our TAM folks are going to go down to a workforce services office and sign up, just not going to happen. So places we have contact with them, the jails, treatment agencies, just community-based organizations, just keeping the opportunity for any place they go, they can get enrolled in TAM would be really key.
Thank you. Great. Joel? Oh, Joel, you're muted now. There you go. Yep,
Can you hear me now?
Can.
Okay. I just wanted to dovetail on what Patrick said. A lot of rural counties are coming out not realizing that TAM is available, so they end up on like traditional Medicaid or whatever. But I really wanted to touch on what you mentioned about CMS and just let the group know that CCBHC, which is something we talked about in this group, was just moved from SAMHSA to CMS. Strange move about a week and a half ago. So it presents, I think, a unique opportunity and an advantage. So I just wanted to put that on the committee's radar.
Okay, thank you. And Dave.
Just as a follow-up to Nina with the housing, I think that's a big issue as well. Just wanted to mention our 1115 housing-related service and supports waiver, which will be starting later this year. So anybody in TAM would be eligible to participate in that waiver as well.
Great.
Okay, thank you for your comments and your contributions with this. Okay, we're going to move to the next slide then, which is sort of the work we're going to undertake today. So we've covered our utilization data, our sort of wraparound services or other supportive services that would facilitate care in this population. We've looked at outcomes. The next step we have is to begin brainstorming models of care that would provide optimal solutions to achieve our person-centered goals for this population. And with this, we would propose a TAM integrated model that would consider the following approaches. The first we would like to propose is that there is an RFI that would allow different groups to submit ideas and their strategies for providing care for this population through an integrated approach. So that could certainly be very informative to us, and different ideas, models, approaches could be presented to us for consideration through an RFI. The second group that we would like to propose is that we use our existing model, which is our fee-for-service delivery model, but enhance it with intensive case management services and what this may look like for this population. The third would be to implement an ACO managed care model that would manage this group. Now, what would we like you to consider as you think about these three different approaches? And this is not an all-inclusive list by any means, but some guidelines for us to consider for each of our options would be, first of all, geography. If we were to implement a model, would we apply it to a rural region, an urban, a regional model, or statewide? Population. We would ask you to consider whether a model that you are evaluating and working in that group would be applied to all of our TAM population, a subgroup of the TAM population, all of our counties of expansion, or a subgroup of the counties of expansion. What are the pros of this model? Do they help us truly achieve our goals? What are the advantages? What are the challenges? What are the cons? What would we have to be very aware of that this model would not necessarily optimally provide, and we would have to address that and be transparent about that. Another large chunk we would like you to consider would be contractual requirements. What would help us optimize care to ensure the greatest success for these populations? So in this, building our, basically our statement of work around our scope of services and what would be required, including even service level of delivery and how we want to see performance standards be put in place for this group. Some other ideas that we'd like you to consider in development of this model is, as we've addressed today, are we meeting the needs of our high utilizer group? But also, just as important, are we addressing the needs of the non-utilizers, those who aren't engaging in care? Are we addressing their needs properly? Okay, because there are a group of individuals that aren't considered high utilizers because they're just simply not engaging. And how do we get them engaged? How do we meet them where they're at? How do we keep them engaged in their healthcare? And I think you've created some great quality outcomes that would help us assess and meet the needs of our entire population. Another idea that was brought up and proposed is value-based contracting opportunities. What are ideas to really drive meaningful value that could have some risk tied to it? So there could be a financial incentive tied to some value components within these models. And what would that look like? What do you think about that? We're going to share this slide deck with you. And we'd love for you to add other thoughts that you may have as you think about anything that we may have missed, but I'll certainly take that feedback now, because the next step of this would be to have you sign up volunteer to participate in one or two of these subgroups. I know it may be tempting to want to be in all three. The purpose of this, of course, would be to break in smaller subgroups. With this, we would have a little more flexibility and maybe perhaps a nimble approach to dialogue and work that we don't have in a meeting of 30 of us, that would be able to really generate ideas. And so I'll go to that slide next. But I want to pause here for a moment and just offer an opportunity for response before we move to the next slide. Are we missing anything? Or is this a good starting place? You can certainly have the opportunity to add other things during the working sessions. Joel.
Recommend, can you hear me?
We hear you.
So I would just recommend maybe looking at timeline.
Thank you.
Yeah, how long we do this before we look at any other type of Medicaid.
Good. Timeline for implementation. I think that's great. Thank you, Joel, because it's true. Some approaches may be more expedient than others, right? So in your evaluation of the model that you may be working in, what would be your proposed timeline for implementation? So I will add that to this deck. Thank you. Any other thoughts, Adam?
Yeah, this is actually, sorry, I'm slow to the punch, but I did have a question about, for Brian, on the high utilizers. Are those high utilizers always high utilizers, or are they high utilizers for like a year and then they go into the lower utilizer category? The reason why I ask that is, like, we might have people who are high utilizers and then they get better and we have a good outcome, and now they're low utilizers. So I just wonder, is that a data element that is discoverable? And I think that might help that conversation, whether we're actually hitting the outcomes that we're wanting already.
Yeah, thank you, Adam. I think that's a good question, and I don't have the answer for that right off the bat. But I mean, we do have programs that focus on that, like our restriction program. A slightly different context, but I mean, that's generally what we do see. The intervention is made and then utilization decreases. So, I mean, I guess we could all make some guesses, but yeah, I'd be interested in pulling that and answering that question for you.
Joel? Go ahead, Joel. Oh, you're now muted, Joel.
You're muted, Joel.
You were not muted, but.
Is it good now?
Yeah.
I just was saying that my hand keeps going up.
Okay, you're muted again, but I'm thinking it unintentionally went up. Is that correct? Okay, thanks. Pat?
Hey, Jen. Jen,
Yes.
This is Tim Whalen. Sorry,
Tim.
I'm calling in. How are you?
Good, thanks.
Really quick question. The first option I heard was possible RFI to see if I'm guessing, are there other national managed care organizations that are interested that could offer a product? And then the second one was the enhanced fee for service. And I'm wondering what you're thinking would be different in the enhanced fee for service versus where we're at now.
Mm-hmm. Good question. So we want to open up the possibility. There were lots of ideas thrown around last meeting around different models, right? And the RFI could be proposing one of these models, right? And you know, would that mean a national provider group or payer with a national footprint would come in? I think that's possible. We really wanted to allow an opportunity for brainstorming of like what this approach could be. We heard a lot of this last week with the CCBHC model, and we thought, well, let's introduce the flexibility through an RFI to see what might be introduced as an option. Does that answer that question?
Jen, could I add?
Yes, Nate.
Jen, could I add to what you were saying? This is Nate Checkett. So Tim, as your question is, could it bring in outside groups? We are still in an any willing provider, any willing plan model. So if other groups wanted to join under our existing structure and join as an ACO or a UMIC plan, they could. Right now, we're open to any willing provider, or any willing plan. So the RFI really, as Jen said, is really looking more at other potential models that might be different rather than necessarily other players that might be different, if that makes sense.
That makes sense, Nate. Thank you.
And then your question around the fee-for-service, the enhanced fee-for-service with case management. Case management services they don't exist today on the fee-for-service side, for example. But we've, considered what this could look like if we would hire case managers and use a case management service for our fee-for-service population. So Tim, that would be an option for this type of approach.
A clarification I would make, I do believe the case management codes are available for the current TAM providers, and they are utilizing that. I'm not a provider, so I'd ask like Adam or someone else to weigh in on that. And that's, I think, what prompted my question.
Okay.
Adam Cohen, are you on there? I heard you a minute ago. You're utilizing the case management codes right now effectively with your TAM population, aren't you?
Not really, because given the environment that we were in before, TCM really wasn't available to the SUD population. So it's just something that we've always done as part of the service delivery system. And then also in residential, TCM is bundled. So it just is, yeah, but it is available. It's really, we use it more on the mental health side.
All right, that's a good clarification for me. Thank you, guys.
Tim, I can expand on that a little bit too. So the TCM codes are open for the TAM through the local mental health authorities. But I see a difference there between a provider providing TCM versus a care management model who can, oversee all the different services this member is getting versus someone who's connecting them to services in a TCM model.
That helps. Thanks.
And Pat, did you have a question or comment?
Yeah, just a comment, on the value-based contracting opportunities, kind of sort of a little different spin on that. I think there's a potential for a lot of profit to be made on this population because, first of all, it's hard to get it into people into services. Sometimes they're not real compliant with follow-up. So if we went to anything like, a capitated model for these individuals and did a prepayment on it, there's a lot of potential for some fairly good profit and maybe not a lot of utilization of good basic care. So what I'd like to see is limiting the ACOs or MCOs, anything to a profit, a margin for profit. Anything over that gets redirected back into some creative services. I mean, Salt Lake County does this now a little bit with Optum for its regular traditional plan, and it's been able to really develop a lot of new services because of that. So in other words, it limits the amount of money people can make on this population and asks for a reinvestment, and I really would like to see that.
Yep. Thanks, Pat. And so I think the subgroup should define a cap on some value-based payments and excess of the cap to be infused back into services.
Yeah.
And you could work on that and define that.
Yeah.
Okay. Thank you. Great. Okay, so what are our next steps as we've thrown something very new at you today? Actually, what we'd like to do are, first of all, to encourage you as a working group member, and those who are not working group members are certainly welcome to join as well, but specifically for our working group members to join a subgroup or two to evaluate one of our 3 proposed models, okay? We will be putting up a Google Doc here shortly and share that with you so that you can put yourself in this. There will also be a Medicaid team member embedded in each of these teams to help facilitate meetings when they occur, making sure that there's someone who can speak to policy, take questions around that. So we will have a Medicaid team member embedded in this as well. The way we would propose this working is that the subgroups will meet outside of the working group meeting and bring their recommendations back to the working group for discussion. So one of the ways that we would also be able to comply with our open meeting acts is by being embedded in a work group, subgroup, we wouldn't have a full quorum of what our full working group is, okay? So if you're to participate in one or two of these and sign up for them, and then do the work, again, our goals of being nimble with our discussions and hopefully generating really good quality content as we already have, but in a smaller group, putting those ideas down, but then bringing that all back to our larger working group for vetting and discussion in a proposal. We would like there to be one working group leader for each subgroup. This leader will facilitate discussion and note-taking, help summarize recommendations in conjunction with the Medicaid team member. So that working group leader will really facilitate and lead, but the Medicaid team member will also be there to help support in any areas that are needed. We have been meeting every 2 weeks. We'd like to give a break on our next meeting, which was scheduled for July 22nd, and actually meet on August 5th. This will allow our subgroups some time to begin doing this work and vetting the models. We really encourage you to actively engage in this and then bring it back. We may need a whole hour to work up each meeting, each model, right? And so we would see the opportunity then for each subgroup to present in the working group. And if it takes an hour and a half of time at follow-up meetings, we'll move back to our every 2-week cycle and present, vet, talk about feasibility, add any missing pieces, engage in our dialogue in the next 2-week sessions. And then if the subgroups need to take it back for more work following one of our working group meetings, we'll do that. How does that sound to everybody? Okay. Great. Thank you. So I've been reminded I can't share a Google Doc outside of our state of Utah account. So if I could, and I just wanted to share with you again our contact information. Brent is on vacation this week, so that's why he's not at this meeting. But he'll be back next time. So Emma.
Hey, Jen, I think if you get a hold of DTS, they have a way of adding people who are outside the state system into a Google Doc, but you do have to have them do a little finagling. So that might be an option.
Thank you, Emma. Sharon, if you would, could you share our working group list that we have and make sure the individuals we've identified are complete according to who's attending now and who we have? Thank you,
Sure.
Sharon.
Yeah, so this is the Google Doc that we have. And so it's on the screen. It's hard to show everyone's name at the same time, but I will just slowly scroll down. And perhaps, Jen, I mean, if people want to email me to sign up, I will definitely work with DTS to get this sent out as well. But you can also email me and I can add you to the list.
Thank you, Sharon.
You're welcome.
Hi, Jake.
Can you please add me to that list, please, Sharon?
Yep. I think you're about the fourth one down, Jake. I thought I saw your name.
Yeah,
Just
you're there.
Yep.
Sorry.
Thank you. Yeah, if you don't see your name, certainly raise your hand. Thanks, Jake, for calling that out. Pat?
Yeah, Sharon, I wonder if you could add Liz Kelch to that too. CLC or KLC, excuse me.
Thank you. I was trying to get off mute to ask you how to spell things.
Thank
Okay.
you.
Yep.
Okay.
And Pat, if you have contact information or if Liz is on the line here, if you could share that with Sharon, that would be great, just so we have that. Nina? Oh, you're muted, Nina.
Can you, sorry about that. Can you remind me what the length of time is we have on this project and the stipulations for the length of the work group?
All right, I'm hoping I can get this correct. We are actually, according to the bill language, it was quarterly meetings. So at a minimum have quarterly meetings. So we are certainly meeting at a enhanced frequency in order to accomplish the work. Our goal was to have potentially something in place by next July. And so, you know, if we can, and Nate, if you could help with this a little bit, because I thought we were comfortable with like a phased implementation, that if there were certain areas or models that were ready for implementation, you know, by July, but other models might take a little bit longer, we were comfortable with that approach. And Nate or Emma, you can correct me if I misspoke.
Yeah, I think that's correct. I mean, as Representative Dunnigan looked at this bill during the session, the motivation behind it was a discussion of moving TAM to ACOs in Salt Lake County with that bill. This bill, in the original version of the bill, or at least the original discussion of the bill, and then this committee and this work group process became an alternate approach to having that discussion. So I think there's a portion of that discussion to say what is practical, what is the right thing to do by July of next year. And then also we've been having this broader discussion about how should we look at the rest, the entire population, and are there other models that may be better for certain areas that may be the best way to move forward in other parts of the state.
And Jen, if I could add, I would just say that as the groups are talking about the models, maybe a couple of other things to take into consideration are the operational realities, even if it is a phased-in approach. Mm-hmm. If it's going to be a plan, or it's going to be a new contract, or it's going to be, you know, that takes usually a minimum of 6 months to, you know, bring that product up. And so just trying to keep that in mind.
Thank you, Nate and Emma. Okay, so this is sort of our new approach. Well, our next approach would be then to have our subgroups with establishing that every 2-week meeting, perhaps after August 5th, if we're productive in really developing our ideas around these 3 different proposed models. And so if you would, in closing, I think our piece now is you're welcome to email Sharon. And Sharon, if you could put your contact information right in the chat. Many of you know you're getting the invite from Sharon. She's sending out the meeting minutes, and she's doing a great job managing and running this meeting for us. So if you want to go ahead and email Sharon about the subgroups you'd be interested in working in, whether that's 1 or 2, if you really want to be in all 3, that's fine too. We are watching to keep the volumes a little bit lower to achieve our goals. The other item is if you are interested in being a leader in one of those subgroups, could you please identify that as well? That you'd be interested in being a work group leader and kind of facilitating and working with the department around scheduling our times and just organizing content and things like that. We would like to provide some standard materials that do allow for data capture to be similar. So we'll make sure this slide deck is transitioned. Some of these bullets are transitioned into sort of forms that you can have at least a standard approach to these elements that were presented today as some initial ideas around, you know, geography, which part of the population, whether the whole population, time frame was another nice suggestion. So we'll provide that for you so you have those resources as well. And then of course, oh, sorry, Nate.
Would it be helpful to set a date that we want that response by, to say by like next Wednesday or something like that, that we would ask people to get that information back to us on their selection on a subgroup and their interest in being a lead.
Thank you, Nate. Great idea. So next Wednesday it is. So let's see, by July 13th, if you could have your response into Sharon. She will also work to share the Google Doc and to kind of get rid of the firewalls for out-of-state employees. So we can share that with you, and then you know who's in your subgroup as well. Okay, are there any additional questions or items for discussion today? I think we've covered the content that Go ahead, Nina.
So as we're bringing ideas forward, what is the structure for final decision making? Is this something that the Department of Health and Human Services has the final say on? These are the models we're going to implement. This is how we're going to. Who makes those final decisions and spearheads the actual implementation?
I think that's a great question. I'm going to defer to my my boss. Nate, do you have a response on that?
Yeah, I think it is a great question too, and it really speaks to the purpose and the nature of the work group and how we're functioning together. Yes, I think you're right. Ultimately, these decisions on implementation are with the Department of Health and Human Services. House Bill 413 spells out a process that we need to go through to make these decisions, and this discussion in the work group, I think, meets some of those requirements there. There's also some other discussions about making sure we've included the counties and some other boxes that we would need to make in the decision-making process. So as long as we're operating within statute, I think ultimately the decision comes down to Health and Human Services, but we very much want to have your collective input on this process and thoughts. Make sure if as we start to head down certain paths, that you helped us identify where pitfalls might be and that we can try to address those and implement in the best way possible.
And Jen, I'm just going to add to, this is Emma again, is that, and we've got CMS as well, the federal government. I mean, they are going to, usually they weigh in on, any sort of, if it's a completely new model that needs to be done through an 1115 waiver, if it's something that's building onto an existing models, then there's still waiver amendments. So ultimately, they're going to have to approve any of these models as well before they will commit to paying the 90% federal match on this population. So that'll be another hoop that we will need to at least another thing that we'll need to cross.
Thanks, Emma. Welcome, Representative.
Thank you.
Okay, with that, I think we've, if there are any other questions, we can take them now. If not, we can adjourn. We'd like to hear from you by next Wednesday on your subgroup, which subgroup you'd like to join, and then we will reconvene as a larger working group on August 5th.
Actually, I have one more question.
Yeah,
if I could.
Sure.
As we're working in our subgroups, some of the questions that might come up, it would be very handy to have folks at your levels when to ask questions of. For example, on these waivers, I'm wondering if any model, no matter what we change, is going to take the same length of time to get approved through the federal steps and or waivers. It'd be very nice to be able to instantly get something like that answered. You said you're going to have representatives from your office in our groups. Will they be able to answer those kinds of questions? Or something to think about is what's the best and fastest way to get those answers from your group? Like, do we have our leader be just in contact with one person, or
that's great.
The best
no, we're going to have
answers.
Yeah, so the director's office on the Division of Integrated Healthcare, as you know, is Brent Kelsey, Brian Roach, Eric Grant, and myself. and we will all participate in one of the groups or two of the groups or so. With that, I'm sure, Emma and Nate may join some of these working groups as well and be a great resource. Dave Wild is an excellent resource as well. Greg Trolin oversees our managed care group, will also participate. So we have our management team that will be participating in these. And if they can't directly answer the question, we'll take it back and be able to respond. Okay.
Perfect.
Yep.
Thank you.
Okay. If there are no other questions, nothing else to discuss at this time, we're really looking forward to the next steps of this process and excited for your input and your thoughts on the different approaches that have been proposed. And again, I want to just express our gratitude for your participation in this important work, and really appreciate the contributions you've made already. So thanks again. We do have many resources to share from today that will be posted to the website and shared with you as working group members. If you need anything from us, you know how to reach us. So thanks so much for your time today. Appreciate the opportunity to do this with you.
Thanks, everybody.
Representative, do you want to hang on the line and I can go through a couple things with you?
Sure, I'd love to.
Okay, great.